So my lecture is about the surgical solutions in male infertility, indications and outcome expectations. Male infertility, of course, we know that it represents about 7% globally. Surgery targets the reversible causes. This is the aim of the surgery, is to restore the natural fertility or to enable the assisted reproductive technique, whether IUI or IVF or XE. Patient selection and couple-based counsel are very critical in managing infertility. If we summarize the surgical indications for treatment of infertility, we can group the indications into three groups. The abnormal seminal parameters with clinical varicocele, so varicocelectomy is the best surgery. In obstructive azoospermia, whether on the level of the prostate or vasal or epididymal obstruction, the aim of the surgery is to reconstruct the sperm pathway. And in azoospermia, non-obstructive azoospermia, the role of surgery is micro-TC for XE, as Dr. Ahmed mentioned. We all know that varicocele prevalence is very high, about 20% of the general population. However, in the primary infertility, it constitutes about 35 to 40%. The pathophysiology includes the hyperthermia that elevates the temperature of the testis, leading to impaired spermatogenesis. Also, it is associated with reduced DNA integrity and Leydig cell dysfunction. The gold standard, of course, is microsurgical varicocelectomy through the subinguinal approach with artery and lymph sparing. The benefits of the microsurgical varicocelectomy, which is the gold standard, is it has the best pregnancy rate and the lowest recurrence and complication rate like hydrocele. Of course, the indications is palpable varicocele, not only visible, not only subclinical, it has to be clinical. With abnormal semen parameters and, of course, infertility. The reconstructive procedures are, as mentioned by Dr. Ahmed, is about which part of the tract, or seminal tract, is obstructed, whether the prostatic. So you have to do TUR-Vero for the ejaculatory duct obstruction relief. Also, if there is vasal obstruction, vasovasostomy has the high patency rate up to 90% when appropriate. If the epididymal obstruction, surgery can offer vasoepididymostomy for epididymal block. However, the success rate is lower, and of course, it's very technically demanding. The outcomes depend on the obstruction site and the interval since the obstruction. So you have to consider this and tell this to the patient that after 5 years of obstruction, probably when you relieve the obstruction, the fertility will not be regained again like before. Dr. Ahmed طبعا he mentioned fully the sperm retrieval techniques, whether in obstructive azoospermia or in non-obstructive azoospermia. I will not go through this. About the outcome expectations, varicocele by evidence improved the semen parameters with spontaneous pregnancy is possible. However, in reconstruction, even with patency, this does not mean the pregnancy. And of course, the time of conception varies. The definition of varicocele, of course, we know the abnormal dilatation and tortuosity of internal spermatic gland within the pampiniform plexus, and the mechanism of varicocelectomy of varicocele appears in this video. This is the scrotum, the testis with the best temperature is 35 degrees for spermatogenesis. However, the spermatic cord, of course, includes the spermatic vessels and the vase, with the artery, testicular artery, giving the oxygen to the testes, and the pampiniform plexus getting the blood away from the testis. And the vas deferens, of course, has its own blood supply. Normally, there is a valve included in is present in inside the testicular veins. However, with incompetence of these valves, there is retrograde flow of blood into the testis, and we know that at the left side is more common than the right side, especially with the nutcracker mechanism, with compression of the superior mesenteric artery upon the left renal vein, which drains the left testicular vein, leading to increased pressure inside the veins, testicular veins, leading to increased temperature and decreased spermatogenesis at the end. The prevalence of varicocele is about 8 to 16% in adults and 15 to 20%. So in adolescents, I mean, and 15 to 20% in adults. However, it is about up to 40% of men with primary infertility have varicocele, with up to 80 of men of secondary infertility have varicocele. As you see here, these are the distribution of from the male infertility clinic with varicocele. About 26% of patients suffering from infertility. Only the second cause after idiopathic infertility. We all know that it's prominently on the left side. However, right-sided varicocele in boys are increasing, and the palpable left-side varicocele with retrograde flow in the right side occurs in 40% of cases. Bilaterality in adults is reported to up to 50% of the case. The primary factors which can lead to infertility in cases of varicocele is the increased venous pressure in the left renal vein with collateral venous anastomosis and valvular incompetence of the left internal somatic. This is the nutcracker phenomena, with the left renal vein, which is draining the pampiniform plexus, is compressed between the superior mesenteric artery and the aorta, leaving to its compression with back pressure on the left testicular vein. This is the proposed mechanism of being the left side more common.